Hi everyone, here in Newcastle and online, and welcome to Newcastle. Welcome to today's Centre of Excellence in Treatable Traits webinar, where we're going to listen to Associate Professor Vanessa Murphy in a minute. But first I'd just like to acknowledge and pay my respect to the Pambalong clan of the Awabakal people, who are the traditional owners of the land on which we are speaking here today. I would also like to acknowledge the traditional custodians of the lands on which each of you online have joined us from today, and welcome. My name's Michael Peake. I'm an obstetrician and gynaecologist. I'm one of the investigators within the centre. And today we're going to hear from Vanessa Murphy about breathing for two, managing asthma in pregnancy and breaking the cycle of asthma in the next generation. But before we do that, it's interesting. I mean, being a maternal fetal medicine person, I quite like medical disorders in pregnancy. And when I was a registrar, I learned when it got to my exams and they suddenly asked me what to do about a medical disorder in pregnancy, all I had to do was three things. One was talk about the effects of pregnancy on the disease, talk about the effects of the disease on pregnancy, and then ended up by just talking about the effects of medications, particularly on the fetus. But I guess over the last 10 or 20 years, it's gone on a bit more from that. In that fact, we have to actually consider the next generation as well in managing medical disorders in pregnancy. And so that's today we've got Vanessa Murphy, who's going to tell us about managing asthma in pregnancy and also a bit on the effects on the next generation as well. A lot of you will know Associate Professor Vanessa Murphy from the University of Newcastle. She's a research scientist investigating the characteristics, mechanisms and consequences of asthma exacerbations during pregnancy and their health impact on both the mother and baby. She is Deputy Chair of the Hunter Medical Research Institute's Asthma and Breathing Program and an MRFF's Investigator Grant Research Fellow. She's an investigator with the Centre of Treatable Traits and led the development of the first online resource for both health professionals and families, the Asthma in Pregnancy Toolkit, which I'm sure you'll hear more about today. And this was launched in late 2022. So thanks, Vanessa.
Thank you very much, Michael, and thanks to everyone who has joined today to listen to this talk. So I'd also like to add my acknowledgement of country and pay my respects to the Awabakal people on whose land we're meeting today, and extend my respect to any Aboriginal people present today. So the first part of my talk, I'm going to speak about managing asthma in pregnancy, and I'm going to be using many of the resources from the Asthma in Pregnancy Toolkit. So please feel free to look this up yourselves after the talk and have a look around the resources we have there. So I'm a scientist and I've been working in this area for the past 20 or so years, and I've been fortunate to work with many clinicians and researchers in that time. So the Centre of Excellence in Treatable Traits has developed the Asthma in Pregnancy Toolkit as an online centralised resource of evidence-based content that is helpful, hopefully, for healthcare professionals as well as families and women with asthma. And I'll just start by acknowledging that the toolkit project manager is Janet Bristow, and that I led this project alongside Professor Peter Gibson and Professor Vanessa McDonald, with funding from a Ramaciotti Foundation grant.
Did you know 13% of pregnant women in Australia have asthma? 30 to 40% of their asthma could get worse during their pregnancy. And 1 in every 2 women with asthma can experience an asthma attack where they need to seek medical help. Help them manage it better with the Asthma in Pregnancy Toolkit. Well-controlled asthma is best for mums and babies.
So as well as the risks of pregnancy on the asthma exacerbations, women with asthma also have increased risks of poor pregnancy outcomes. And these include preeclampsia, low birth weight and preterm birth, as well as an increased risk of neonatal hospital admission, gestational diabetes and caesarean section birth. 1 in 10 women may require oral corticosteroids for an exacerbation, and many more than that will need to seek help from their doctor or an emergency department or hospital. And when women have exacerbations during pregnancy, they are then at even further increased risk of poor perinatal outcomes, particularly low birth weight and preterm birth. And there's an increased risk of their child developing asthma. So this is one of the infographics from the toolkit that looks at asthma exacerbations. They're common in pregnancy and they are often triggered by viral infections. One of the things that we found from a recent systematic review is that there are some maternal risk factors for asthma attacks in pregnancy, including more severe asthma, cigarette smoking, older age, obesity, multiparity, and depression and anxiety. And the important message for exacerbations is that they should be managed the same as for other adults, including the use of oral corticosteroids. On the bottom of this infographic, we have some signs and symptoms of an asthma attack and a place to go for asthma first aid advice. So back to these increased risks, as I mentioned, that exacerbations increase risks further. But what's really interesting from the literature is that active asthma management lowers the risk of some of these outcomes, in particular preterm labour and birth, neonatal hospital admission and gestational diabetes. So this is an example of a meta-analysis where there were 15 studies looking at preterm birth. In studies where no active management was given, the risk was 1.5. However, in the studies where there was active management, it was reduced to a non-significant level. So what is active management? What I'm going to talk about today are the 5 key aspects that are recommended in the guidelines. And we conducted a review and appraisal of these guidelines a few years ago and found that these are the 5 consistent messages that are given in the guidelines for how asthma should be managed in pregnancy. The first of these aspects is regular review of symptoms or control of asthma every 4 to 6 weeks, and this includes giving an updated written asthma action plan. And the reason for this need in regular review is that asthma symptoms can unpredictably change with pregnancy and may vary from pregnancy to pregnancy. While the traditional thought was that 1/3 of women worsened, 1/3 improved, and 1/3 stayed the same, there has been more recent evidence of 2 trajectories. 60% of women having no change in their symptoms in pregnancy, and the other 40% having worsening symptoms. Although, interestingly, on this graph, you'll see that symptoms again reduce in very late pregnancy. Every person with asthma should have their own written asthma action plan. And this action plan template on the right is from Asthma Australia. And what an action plan does is outline the steps of what to do if asthma symptoms do worsen. So in the green section is a description of what well-controlled asthma looks like. Not needing to use reliever medication more than 2 days a week, not having asthma at night or on waking up, and being able to do all your activities. And the doctor can put in what preventer and reliever medication a woman should be taking. In the orange section is a description of what a flare-up or an asthma attack or an oncoming exacerbation might look like. For example, needing more reliever medication than usual, waking up at night with asthma, or not being able to do all your activities. And then the steps to take in terms of medication use are given on the right. And there may be a need to start new medication at this point or to make an appointment to see the doctor. And then in the red section is what happens what you should do when medication's not lasting 3 hours or you're waking up frequently with asthma. And these plans are really important. And unfortunately, not enough people with asthma have a written action plan. In our studies, we've found that only 15% have one. The second part of the recommended management for asthma in pregnancy is around asthma medication. Women should be encouraged to continue to take prescribed medications. In general, inhaled corticosteroids are considered safe in pregnancy and breastfeeding, and further discussions with a GP or a respiratory specialist may be required. So on the asthma and pregnancy toolkit, we have a section on medications, and there's a table here that outlines the commonly used medications in pregnancy, what their action is and their safety. And this information has been taken from a recent European Respiratory Society and Thoracic Society of Australia and New Zealand Task Force statement. And the terminology that's used here for safety is compatible, probably safe, and possibly safe. And compatible indicates the first line treatment that has evidence of safety, most generally from long use of these medications in pregnancy. Probably safe is given to drugs that are of a similar drug class to those that are compatible, and possibly safe are second-line treatments that might be considered in certain situations. So for short-acting beta agonists, as you see here, salbutamol is considered the most safe due to its long history of use and the available data on safety. For inhaled corticosteroids, budesonide, beclomethasone and fluticasone are all given the compatible rating, again due to their long history of use and a large number of database studies, particularly from Scandinavia, that indicate safety. And the inhaled corticosteroids and LABA combinations are listed here as well, with the probably safe. So inhaled corticosteroid use is an interesting area in pregnancy. So this systematic review and meta-analysis looked at the prevalence of pregnant women who take inhaled corticosteroids for asthma. And across the world, the prevalence was 41% of women using ICS. And this was slightly higher in Europe than North America. In addition, there's a well-documented pattern where prescriptions for asthma medications drop in the first trimester of pregnancy. So on this figure, you'll see the red dots represent the pregnancy period, and there's a distinct drop in the first trimester, which interestingly increases again in the middle of pregnancy. And this might be related to the fact that exacerbations are more likely to occur in the second trimester. It then drops down again in the third trimester and the early postpartum period. And this data comes from 8 European databases that were combined, but it's also been observed in data from the United States. On this graph, you'll see that there is a 23% decline in the use of inhaled steroids in early pregnancy, a 13% decline in short-acting beta agonists, and a 54% decline in oral corticosteroids. Now, why might this be happening? It's possible that this is related to perceived risks that women have about the risk of asthma medication on the fetus. And some years ago, we did a study where we asked women to rate on a visual analog scale what they thought what their risk of each medication type was. And this scale went from 0, which was no side effects, healthy baby, to 10, which was labelled severe side effects. And we did some qualitative work that ascertained that 0 to 10% was considered no risk, 10 to 40, slight risk, and over 40, quite a risk. And at the beginning of the study, visit 1, women were more likely to considered OCS to have the greatest risk, controller medications like inhaled steroids, the next greatest, slight risk, and reliever medications to have some risk. And you can see that with repeat educational visits during the pregnancy, that these perceived risks were reduced. So for oral corticosteroids, the key messages are that the benefit in severe asthma exacerbations is thought to outweigh any possible fetal risk, and they should be prescribed as for non-pregnant women. However, the ultimate goal of management being to reduce the risk of exacerbations occurring in the first place. There's some interesting data from the US that shows that women who are pregnant are less likely to be given oral corticosteroids in the emergency department setting compared to women who are not pregnant. They're also less likely to be given oral steroids on discharge from emergency departments and are more likely to have an ongoing exacerbation or to represent to the emergency department within 2 weeks. There is one paper that looked at 2 time periods and found that these trends had reduced in the later time period. But this data such as this has not ever been looked at in the Australian context. For monoclonal antibodies, there is very little published data on these in pregnancy. There is one study, a registry, the EXPECT registry, that has published data on the use of omalizumab in pregnancy. And this was looked at in about 230 pregnancies and compared to a comparator cohort of women with moderate to severe asthma who did not use monoclonals or did not use omalizumab or other monoclonals. And there were no differences in the outcomes such as stillbirth, congenital abnormalities, preterm birth and birth weight. So the key messages on monoclonals from the Asthma and Pregnancy Toolkit are that patients who are already on monoclonals should continue in pregnancy, but the decision to start biologic treatment in pregnancy should be carefully considered and discussed with a specialist. So moving on now to the third aspect of recommended management in pregnancy, and that is multidisciplinary management, so the involvement of the obstetric care provider. We've previously studied a group of midwives. We did a qualitative study to look at what they thought their role might be in the provision of asthma care in pregnancy. And midwives wanted to have a role in the education of pregnant women about their asthma, but they lacked the knowledge to carry out the role. And they suggested health professional education about asthma management as one solution to this barrier. And that was one of the reasons we wanted to develop the toolkit in the first place, to provide information for antenatal care providers specifically. In this graph, we have the results of a survey where we asked maternity carers, this included midwives and obstetricians, primary carers who included GPs and practice nurses, and respiratory specialists, physicians and nurses. We asked them about their confidence, knowledge and guideline use for asthma in pregnancy. And for the maternity carers, less than 20% felt confident or had good knowledge, and 50% used guidelines. On the Asthma and Pregnancy Toolkit, we have some examples of different models of care that can be used to support the management of asthma in pregnancy from different places around the world. So one of the examples is from the Royal Hospital for Women in Randwick. In the case of mild asthma, the care is led by a midwife and supported by the GP and obstetrician. In the case of moderate asthma, the care is led by the GP, who's usually doing shared care, and supported by the obstetric physician at the hospital. And in the case of severe asthma, women go to a high-risk obstetric physician hospital clinic, and care is supported by a respiratory physician. The example from Manchester was that for mild and moderate, well-controlled asthma, care is led by the GP. In the case of uncontrolled mild or moderate asthma, there's a general asthma clinic. And for severe asthma, they run a severe asthma specialist multidisciplinary pregnancy clinic, which includes a specialist nurse, a medical consultant and a pharmacist. Here in Newcastle, women are screened for asthma by midwives at their first antenatal visit and referred to the Antenatal Asthma Management Service, where they have their first consultation with a nurse specialist and a second consultation with a respiratory physician. So these are some of the examples of ways in which asthma can be managed in a multidisciplinary way that includes the obstetric care providers. So the next section is around the management of comorbidities or treatable traits. And for those who are less familiar with the treatable traits concept, this represents a personalised model of care where traits are assessed and treated. So to be a treatable trait, trait needs to be clinically relevant, identifiable and measured, and treatable. And traits are generally categorised into one of three domains: the pulmonary domain, the extrapulmonary domain, and the risk factor behavioural domain. This is one of our infographics from the toolkit that outlines the treatable traits concept, some common traits found in pregnant women with asthma, and some evidence So there's limited evidence on the effectiveness of treatable trait management for asthma in pregnancy, mostly around pulmonary traits and showing a reduction in exacerbations and improved asthma control. On this pie chart, you'll see on the left the traits that have known prevalence and clinical importance for asthma in pregnancy. And on the right are the potential traits that have either unknown prevalence or unknown clinical importance. So for the pulmonary domain, quite a lot is known about T2 high inflammation, airflow limitation and symptoms, and respiratory viral infection. And I'll talk a bit more about these shortly. For the extrapulmonary domain, there's been numerous studies on obesity and excess gestational weight gain, as well as depression, anxiety, and rhinitis. And in the behavioural domain, studies have been conducted on smoking, showing that smokers are more likely to have exacerbations of asthma in pregnancy. There's been work done looking at written action plans, inhaler device technique, and non-adherence to inhaled corticosteroids. On the other hand, for the pulmonary domain, we don't know anything about breathlessness or dysfunctional breathing in pregnancy or the importance of asthma in exacerbated disease. In the extrapulmonary domain, there's very little literature about reflux, even though reflux is a common complaint in pregnant women. There's nothing known at all around sleep apnea and vocal cord dysfunction in the context of asthma in pregnancy. We know that iron deficiency and anemia are very common, but we don't know if this has any clinical importance in the context of asthma in pregnancy. And there are studies showing that women who have asthma are more likely to have hyperemesis, gestational hypertension, gestational diabetes, and vitamin D insufficiency compared to women without asthma. But again, their clinical importance in relation to asthma outcomes is not known. In the behavioural domain, there's no information currently around vaping, the use of e-cigarettes in the context of asthma in pregnancy. There's no studies on physical inactivity or sedentary behaviour. There's very little known around poor nutrition and poor health literacy. So there's still a lot of research to be done in this area. So just to talk about some of the things we do know in the treatable traits pulmonary domain, asthma can be characterised as T2 or type 2 inflammation high or non-T2, type 2 inflammation low. And we characterised women as having T2 high or low asthma based on their levels of exhaled nitric oxide and blood eosinophils in a study of 195 pregnant women. And we found that just over half had low FeNO and low blood eosinophils. 25%, around 13% had eosinophilic asthma characterised by high FeNO and high blood eosinophils, and the others were discordant for these two biomarkers. So fractional exhaled nitric oxide, or FeNO, is a useful biomarker in the pregnancy setting, given that it's non-invasive and easy to perform and provides a result quickly. Nitric oxide is produced by the epithelial cells that line the airways, and production of nitric oxide is increased in the presence of T2 inflammation, with elevated levels associated with exacerbations and corticosteroid responsiveness. So we did a study called the Managing Asthma in Pregnancy study, which was an RCT, to look at whether managing asthma according to FeNO levels would reduce exacerbations in pregnancy. So the control group in this study had their treatment stepped up or down according to their symptoms, and the FeNO group had their treatment stepped up or down according to both FeNO and symptoms. And the study was done in 220 non-smokers. What we found was that the exacerbation rate in pregnancy was reduced by 50%. And more women were given inhaled corticosteroids as a result of the treatment algorithm, but at a lower mean dose. More women also ended up using ICS-LABA combination. So this is one example of a treatable traits management approach that was effective in pregnant women with asthma. Another aspect of the pulmonary domain is lung function. And on the right-hand side here, I've got some figures that show modelled data from over 1,000 pregnant women with and without asthma, where we've looked at forced vital capacity and forced expiratory volume in 1 second and the ratio. And while there were some significant differences between asthma and control or across gestational age, they were very small and unlikely to be clinically important, meaning that abnormal spirometry in a pregnant patient should prompt an evaluation of possible respiratory disease. The other aspect of the pulmonary domain that's been well studied in pregnancy is viral infection, which are a common cause of asthma exacerbations. There's a recent paper that looked at the risk of SARS-CoV-2 infection in pregnancy and found that women with asthma were at increased risk. They were also at increased risk of severe disease requiring hospitalisation. On the right, you'll see some data from a study we did some time ago looking at common colds in pregnant women with and without asthma. And what we found was that women with asthma were more likely to have respiratory viral infections. And we also looked at characterising what infections they had, and those that had PCR positive colds, 1 in 3 had an exacerbation requiring medical intervention. So moving now to the extrapulmonary domain, there's been a number of studies which have examined anxiety or depression in the context of asthma in pregnancy, with studies showing that around 1 in 3 pregnant women with asthma report anxiety or depression. In the bottom right-hand corner, this is results from a study conducted in Adelaide that showed that women who had a diagnosis of anxiety or depression were more likely to have uncontrolled asthma symptoms in pregnancy. And a recent systematic review that we conducted showed that anxiety or depression was a risk factor for exacerbations. With obesity, it was also identified in the same systematic review as being associated with an increased risk of exacerbation. And on the right is some data from a prospective study showing that women who were overweight or obese at their first pregnancy study visit were twice as likely to have an exacerbation during pregnancy. In the risk factor behavioural domain, there are many traits that are common among pregnant women with asthma, particularly smoking, excess gestational weight gain, which we found occurred in more than 70% of participants in our studies, and suboptimal self-management skills. There's less known about physical activity. So this is one of the infographics from the Asthma in Pregnancy Toolkit. And on the left, you can see the impacts of physical activity on asthma. There's been studies showing associations with better asthma control, improved quality of life, less asthma symptoms and exacerbations, and a reduction in anxiety and depression symptoms. And on the right, you can see the benefits of physical activity in pregnancy, which include a lower risk of gestational diabetes, less back pain and incontinence, and reduced risk of postnatal depression. But no studies have yet put these two populations together to see what effect physical activity might have in asthma in pregnancy. So the last component of the recommended management is education. And this includes assessing inhaler technique, checking medication adherence, and reinforcing the importance of good asthma control.
Did you know only 2 in 10 pregnant women with asthma use the correct inhaler technique? Help women to get this medication to where it's needed. Well-controlled asthma is best for mums and babies.
So in addition to only 2 in 10 women having optimal inhaler technique, only 3 in 10 had correct knowledge of what their medications were for, and 4 in 10 were using inhaled corticosteroids. In addition, non-adherence is a common problem in pregnancy. And what I'm describing here is slightly different to what I described earlier, which was the cessation of medication use with pregnancy. This is self-reported non-adherence among users of inhaled corticosteroids. And at the beginning of the study, 41% of women reported non-adherence in the past week. And with repeat educational visits monthly, we were able to see this reduced to 22%. However, there was a rebound to over half of women being non-adherent at 6 months postpartum. That same graph is on the top left here, and then the others show the improvement in reliever knowledge, controller knowledge, and inhaler technique with repeat educational sessions. And in all of these cases, those skills were maintained at 6 months postpartum. This is one of the tables from the toolkit, which shows some of the common reasons women give for not wanting to take their asthma medications. The most commonly reported one being the taste or throat and mouth symptoms, followed by the thought that the medications were unsafe in pregnancy. And then we have some recommended solutions for these issues. Again, one of the toolkit infographics showing the cycle of non-adherence, where poor adherence leads to worsening symptoms and increased reliance on reliever medication, which may reinforce the ineffectiveness of the preventer or the ICS medication, leading back to more non-adherence. So that's where I'm going to leave this first part, talking about the management of asthma in pregnancy. I'm going to move from one cycle to another, and that brings me to the second part of the presentation, talking about breaking the cycle of asthma in the next generation. So pregnancy is a key time point where the health of the mother can influence the trajectory of health or disease in the next generation. And this concept is known as the developmental origins of health and disease. This graph from a recent paper published in BMJ Open shows the various components, the patient characteristics, family history and environmental factors, which have been shown to be associated with asthma diagnosis in children. And what I wanted to highlight was that many of these factors are either related to the pregnancy or very early life, or are also relevant to the pregnant mother who has asthma. So things like the microbiome of the mother is also potentially important for asthma in the child, rate of weight gain during pregnancy. In terms of environmental factors, the use of medications, including antibiotics by the mother, are also important, as well as her diet, infections and tobacco use, stress and air pollution exposure. So in terms of the parental history and risk for childhood asthma, having a mother with asthma is the single biggest risk factor for developing asthma in childhood. And this study showed that kids whose mothers had asthma were 5 times more likely to get asthma themselves under the age of 5. And this was compared to their father having asthma, which was an odds ratio of 1.6. More recently, there's been a meta-analysis of 33 studies, which showed that the odds of a child having asthma when their mother had asthma was 3, and the odds when their father had asthma was 2.4. And these odds ratios were significantly different from one another. So asthma is associated with asthma in the mother is associated with a 3 times increased risk of asthma in the child. There are also other studies from Quebec and the US which show that moderate or severe uncontrolled asthma in pregnancy, which included having an exacerbation in pregnancy, increased the odds for asthma in the child and increased early onset persistent asthma. And in addition, mild uncontrolled asthma was also associated with more asthma in the child compared to mild controlled asthma. So is this relationship between maternal asthma and childhood asthma modifiable? Well, coming back to the MAP study results, where we use the treatable traits approach of modifying treatment based on pheno and symptoms, we think that it is. So this graph here shows the results of a 4 to 6 year follow-up of the children who participated in the MAP study. And when their mothers had been treated according to the pheno-based approach, they were significantly less likely to have doctor-diagnosed asthma, frequent wheeze, short-acting beta agonist use, and emergency department visits for asthma in the previous 12 months. And why might this have happened? Is it potentially because of the reduction in exacerbations that we saw in the mothers? Well, it could be, but we also found an interesting relationship with inhaled corticosteroid use in pregnancy, where the group who had pheno-based management, but their mothers also used inhaled steroids at randomisation, were the group that was the least likely to have doctor-diagnosed asthma. So the treatable traits approach was shown to reduce bronchiolitis in infancy, which I didn't show you, and asthma in preschool age. But are there any other interventions that might modify this relationship between maternal asthma and childhood asthma? And breastfeeding is one of those that may do this. This graph shows a meta-analysis that was published in 2021, and it showed that more breastfeeding and more exclusive breastfeeding were associated with less asthma in childhood. However, as you see in the red box here, the relationship was significant and stronger in children under the age of 7 and was no longer significant from 7 to 12 years of age. We've also been interested in breastfeeding and its effects on wheeze in infancy. And this systematic review and meta-analysis looked at studies where infants had a family history of asthma or allergy. And the odds ratio for wheeze at 12 months of age was reduced by 32% when children had been breastfed compared to not breastfed. And in this slide, you'll see the results from the MAP study and another similar study we did called BLT, where we applied IPDMA methodology to the data. And what we found was that the risk of hospital admission or healthcare utilisation, whether it be hospital admission or ED, presentation or consultant referral for asthma, or wheeze, was significantly reduced significantly reduced at both 6 and 12 months of age in children who had been breastfed. So breastfeeding is important. However, the rates of breastfeeding have been shown to be lower in women who have asthma in pregnancy, both compared to the general population and compared to WHO recommendations. And so while any breastfeeding is beneficial and longer or more exclusive breastfeeding may give further benefit, we need to understand more about why women with asthma don't breastfeed as much and what support they might need to prove this. So I'm now going to move on to talk about one of the studies that we're doing to try and understand the early life origins of lung health, and that is the Breathing for Life trial. So this trial was very similar to the MAP study. It was a pregnancy RCT where women were randomised to a control group who had usual care for their asthma. They had no treatment changes as part of the study and just one baseline visit for asthma education and assessment. And they were compared to the pheno group, which had their treatment stepped up or down according to pheno and symptoms, as in the MAP study. However, in this trial, we changed their treatment every 6 to 12 weeks rather than every month. And that this group had regular visits with the research nurse or midwife at the time of their antenatal appointments. It was a multi-site trial involving 1,200 pregnant women with asthma, and 731 of these were from our Newcastle site. The primary outcome for this trial was a composite outcome of a preterm birth, birth weight less than the 10th centile, perinatal mortality or NICU admission at birth. And I'll tell you the short story now that there was no significant difference between the groups in the primary outcome. However, the trial has turned into a birth cohort, and we are following up these kids to investigate the early life origins of asthma and respiratory disease, and also investigating nutrition and neurodevelopment. So the respiratory follow-up is collecting information on cord blood immunology. Lung function assessments have been done at 6 weeks as well as 4 to 6 years. We have information on wheeze symptom trajectories. We're applying for linkage of administrative data to look at healthcare utilisation. We'll be looking at DNA methylation in newborn blood spot cards and allergies by skin prick test. And we're also particularly interested in air pollution exposures such as bushfires. The nutritional follow-up is looking at breastfeeding and diet, both for the mother and the infant. We're looking at growth trajectories and body composition each year up to 3 years of age. And the neurodevelopmental follow-up has been studying sensory processing and temperament, infant-directed speech, looking at cognitive, motor and language skills using the Bailey scales, and looking at autism likelihood in infancy and now at preschool age. So this is some of the people involved in the BLT birth cohort, and there are many others, so I just want to acknowledge that that's a big team effort. And we hope that by understanding more about what happens during pregnancy and in early life, that we may one day be able to break the cycle of asthma in the next generation. So to finish off today, I'm just going to give some final key messages about managing asthma in pregnancy. So the key messages are that asthma should be treated in pregnant women as it would be in non-pregnant adults. And this applies for both the use of maintenance medications and exacerbation management. And all women should have a written asthma action plan. Communication with the woman's other care providers is important, whether this be a GP or midwife or an obstetrician. And more research is needed on treatable traits prevalence, clinical relevance, and whether a management approach incorporating more traits improves outcomes in pregnancy and early childhood. So thank you very much, and I'm happy to take questions. Please check out the Asthma and Pregnancy Toolkit.
Thanks, Vanessa. For those online, if you've got any questions, you can use the Q&A panel, and Vanessa, number 3, will look the questions up for you and we'll ask them. But first of all, anyone here in the audience have any questions at the moment for Vanessa?
Thank you for a lovely presentation, Vanessa. I'm a little curious on the numbers you said, like we've said for many years, 1/3, 1/3, 1/3. And you said that 40% has worsening of their symptoms. Is that in women who actually take their medication, or is that due to them being non-adherent to the medication?
That's a really good question. And that figure comes from a study where women completed daily diary cards throughout the pregnancy. I can't recall right now whether they looked at adherence at all in that study, but it was a very well characterised population of about 330 women in the US. So yeah, I'd have to look back at that paper to see, but that's a really good question, because obviously for some women the worsening might be because they're not taking their medications properly. Yeah.
Perhaps what you're thinking, I've got one question.
Mm-hmm.
I mean, it's known that women with well-controlled asthma with less exacerbations have better perinatal outcomes. How does that work?
That's a great question, Michael. So the relationship between poor asthma control and poor perinatal outcomes is not completely understood. There are several potential mechanisms for that effect. There could be inflammatory mechanisms related to having an exacerbation or a flare-up that affects the outcomes for the baby. There might be hormonal reasons that asthma gets worse that might be related to poor perinatal outcomes as well. It's not well understood why that is. Yeah. And in the Breathing for Life trial, there was a disconnect between improving exacerbations but not improving perinatal outcomes, which was surprising to us because we all the other literature suggests that it's exacerbations that are related to poor perinatal outcomes. So we need to understand more about that.
Okay, Peter?
What's been the feedback when people look at the toolkit so far? Are any parts used more than others?
Mm-hmm. Yeah, so the medications page is the most used page apart from the introductory asthma and pregnancy component. So I think that's interesting that is an area that people want to know more about. The feedback has been really good. We've only had about 20 people do our user survey, so I would encourage the audience to please go and look at the toolkit and take the survey so we can get more feedback on the toolkit. But generally, we've had feedback that it's useful information and well laid out and a good content.
Perhaps just a follow-up question to that. I mean, looking after pregnant women and trying to do things like asthma and pregnancy is very difficult because pregnant women are looked after by midwives, by GPs, by obstetricians, both in the public and the private sector. I mean, strategies you've been looking at to try to, I mean, you've got the toolkit, but strategies you've been looking at to try to get the information to all those groups?
Yeah, that's a really good point. And so one of the things we've been doing is we've had endorsement of the toolkit by Asthma Australia, which is the peak consumer body. We've had endorsement from the Society of Obstetric Medicine in Australia and New Zealand, and we'll be pursuing that with other professional societies. We've been conducting a dissemination program in the ACT this year. You probably saw some of those videos had supported by ACT Health. We've been promoting messages around the importance of well-controlled asthma to the public via digital ads and social media, as well as running a series of health professional workshops with the primary care network and within the hospital system and the universities to try and reach students as well. And yeah, we hope to publish data from the toolkit surveys and the other work that we've been doing around dissemination and spreading the word, particularly, as I mentioned, to antenatal clinicians who don't have asthma mentioned in many of their guideline documents. So they really need a place to go to find this information.
Any other questions at the moment? I've got another one.
Sure.
I mean, I'm very interested in trying to look at ways to reduce asthma in the next generation. You talked about that and mentioned some ways to possibly do that. On the Channel 7 News 2 days ago, there was a Melbourne group who put out data which linked food allergies in children with developing asthma later in their childhood, including even in children where food allergies went away, they're more likely to get asthma and also altered lung function. I mean, what are your thoughts in this whole way of trying to reduce asthma is the role of food allergies?
Yeah, interestingly, food allergies are becoming much more common. And we know that children who have one type of allergy often develop other types, and sometimes asthma has an allergic basis. And so there might be an association there. One of the studies that we've been doing within the Breathing for Life trial looked at the immune cells in the cord blood and showed that the types of cells that were present at birth were associated with lung function at 6 weeks of age. And at 6 weeks of age, kids are unlikely to have been exposed to a lot of environmental exposures like viruses, hopefully, at that age. And so this really, really early lung function is related to what sort of immune cells are in the cord blood. And so I guess that suggests that from very early in life, the immune system might be programmed to go down the path where lung function is reduced, and that sort of understanding these what cell types are there and what's happening in terms of the immune system might be really important in understanding that link.
And you also talked a little about the microbiome. Is that in the lungs or in the uterus?
We've actually been looking at it in terms of the gut microbiome, but of course there's microbiomes all over the place in the respiratory tract, the vaginal microbiome. That's not something we've looked at in VLT closely yet, but is certainly an area of interest. And I mean, the vaginal microbiome is likely to play a role because it's known that children who are born by caesarean section are more likely to have asthma. And so, yeah, there's all sorts of relationships likely to be happening there.
Okay. Any other questions at the moment? I mean, just going to allergies and relationship with asthma. I know there's a lot of big trials going on around the world in Australia trying to reduce childhood allergies by, perhaps giving mothers extra eggs or peanuts during pregnancy. I mean, if a pregnant woman, mum-to-be, came to ask you right now, what should I do during pregnancy to try to reduce asthma in my child, what would be your advice?
Well, first of all, let's say I'm not a doctor, I'm a scientist. So I can only speak to what the literature tells us. And what the literature tells us is that if you need prescribed asthma medications, you should keep taking them. If you're concerned about that, you should talk to your GP or your doctor or midwife. The best thing to do is to keep your asthma well controlled. So avoid things that trigger your asthma, take your medications. And if you notice a change, have an action plan. Ask your doctor to give you an action plan. That's probably a really big one that women can go out and do that could change things for them. And make sure you do what you can to keep your asthma under control. And if you notice it worsening, go and see your doctor.
We might end it there, and it's been a great talk. Thanks, Vanessa. Very interesting, and just like everyone to thank Vanessa.